All right, so anyway, here's the wish list. You know, we've got to at least get it out there. I think we all know kind of what we need to do, but, you know, obviously biomarkers of exposure would be the ideal. If we could find a marker or set of markers in the blood or serum, that would be an indicator that somebody is getting exposed, and at a molecular level, we could tell that, and that would be ideal, which is obviously a very difficult thing to do, and certainly I don't think anybody's quite close to that at all, but certainly biomarkers of disease can be improved a lot. There may be blood markers. We have some work going on with UPenn where we're looking at blood markers. So anyway, imaging. We know imaging needs to improve, and once again, there's an area we're going to talk about tomorrow, and I'm hoping that David said he would fill in for Tony Reeves, who couldn't make it. Are you shaking your head, David? Oh, okay, good. And so I think we'll talk about that tomorrow. And but what I wanted to address is on this same topic of autoimmunity, and why do I think that why am I have such a strong opinion about autoimmunity being a mechanism in some people with Libby-amphibole fibrosis? And so imaging for detection and characterization of pleural and lung fibrosis, the automated imaging analysis technology with computer aid is developing, and once again, David will talk about that more tomorrow. So anyway, I'll say, what about the relationship to autoimmunity, and why do we think that there's such a strong association here, besides the case I showed you and many others like that? You know, because of the characteristic of the disease. The disease is a parietal pleural disease, but normally in the typical asbestos exposure, plaques are the most common manifestation in the pleura. I would say that diffuse pleural thickening or a layering that we see in the Libby population may be in 10% of those exposed to chrysotile, much less common. In our population, it's predominantly a thin layer, with plaques being a much less common pleural manifestation of fibrosis. And so the people that are the sickest usually have the diffuse pleural process and not the plaques, though the plaques can certainly progress to a diffuse process. So anyway, the histologic appearance of plaques is basically that we have a fibrotic layer that's humped up and usually stands out, it's easy to see, but it's usually acellular or has very few cells within it. It does not show any signs of inflammation. And in the pleural tissues that we have about, well, right now we have 32 patients who required procedures in their chest where we were able to obtain the tissue for other analysis. And 84% of the tissue samples showed chronic inflammatory cells, usually lymphocytes. But it's a consistent pattern in all the pleural tissue we get. There's an inflammatory process. So the disease appears mainly to be related to a chronic fibrous pleuritis, which once again falls into a very kind of nonspecific category. It's a common problem with many different conditions. And then, of course, at the top of the list, you know, asbestos exposure is one cause of this chronic fibrous pleuritis. Collagen vascular diseases, just what we've been talking about. I mean, they're clearly right up there on that list. There are other causes that are easily ruled out on history alone for the most part. But these other conditions can also cause a fibrous pleuritis that's chronic. But anyway, that creates the dilemma that we continue to talk about. But the close association is there based on the histopathology and the crossover with other conditions like autoimmune disease. So the other thing with this is these episodes of rapid progression, that's not reported in the literature. Maybe once. I think there's only one report, and it was totally unrelated to pleural disease. Matter of fact, it was interstitial disease. But we see a pattern of flares where in 1 to 2 years somebody goes from good lung function to where they become short of breath, sometimes associated with chest pain, commonly, and a advancement radiologically of their pleural fibrosis. And why does it turn on like that after 30 years, and then boom, it'll just take off. And then over a couple of years, they lose that. And then after a couple of years, it'll start quieting down, and they go through a plateau phase, and then may stay like that for a number of years, and then flare at a different time. So there's not this continuous, traditionally thought chronic inflammatory process that gradually adds up fibrous tissue over time, and it's insidious. It comes in these bursts of dramatic loss of function with pulmonary function and radiologic changes. So that's not your traditional pattern of asbestosis. And then the other thing is chest pain. Chest pain is reported with pleural disease. It's not thought to be associated with plaques, although obviously in our population that's a different story. But chest pain, and not just simple chest pain, moderate to severe, the kind that interferes with somebody's life, requires some levels of pain management, and it's not uncommon in our population to see this. That's not true in general with asbestos disease. So we're dealing with a prominent sinusitis, which is, once again, fits with the chronic fibrous pleurisy. And so there's a real crossover here, and it always presents that thought, well, why wouldn't this respond to the medications that you would use for somebody with autoimmune disease too? So,
when does the pain coincide with the active period?
Generally it does, but not always. Sometimes pain is the main symptom, but they don't progress necessarily. I've got cases I could show you, but I don't have them here today, but they have pain for sometimes several years before you see the pleural changes. They'll hurt, mostly in the posterior thorax. They'll have a lot of pain, and it's pretty classic the way they present. And then over a few years, you start seeing the pleural thickening build up in the posterior lower chest, and that's a common pattern. But usually it is progression with the pain, or pain with the progression. So anyway, and the other thing is, and we're back on this other thing of, what about these people that we keep seeing that have lung disease and they're chronically fatigued? Now, I'm talking about, I'm tired, I ache here and there. These are debilitated people. They're people that have worked hard, and they're with their lung disease, they start developing these symptoms. I'm sure Roger probably sees this type in the office fairly often, I would imagine, huh? So, and it's really hard. If it wasn't such a continued pattern, you wouldn't think nothing of it other than, gee, I'm sorry. We'll do what we can for you, but this has always been a challenge for us, and I don't, there's no magic treatment for it, but it is an observed pattern. So vague symptoms, but that's what autoimmune disease is like. It's a lot of vague symptoms with it, but fatigue is dramatic and just generalized discomfort to a degree that impairs them from really functioning well. I mean, that's clearly still the area that it seems to need a lot of work. I think like Gene, we've shown that mice with the mesothelial cell autoantibodies they produce fiber, and they cause the production of fibrosis. We just haven't shown that in people, but that's an area that still needs to. And I'm sure you have ideas. If you had money, you would have lots of ideas, wouldn't you, Gene and Kent? I'm sure. So yeah.